Good morning, everyone. I'm an undergrad student at Maharat Nakhon Ratchasima Hospital. My name is Teerapat Kurirung, supported by my professor, uh, Dr. Siriya Kitiyodom, Department of Obstetrics and Gynecology of Maharat Nakhon Ratchasima Hospital. Today, I will be presenting the finding of the study conducted at Maharat Nakhon Ratchasima Hospital, uh, where we examine the potential of Inhibin A. As a biomarker of predicting preeclampsia during the second trimester of pregnancy. Preeclampsia is a severe pregnancy-related conditions that can lead to the significant complication for both maternal and fetal health. So the early detection is the key to improve the outcome. So the first, I will walk you through the background. Preeclampsia is categorized by the high blood pressure and the proteinuria. After the 20 weeks of pregnancy, if untreated, it can result the life-threatening conditions such as organ failure or seizure. And in Thailand, the quadruple test is routinely used for prenatal screening, mainly for the Down syndrome. However, it also measures inhibin A, which has been suggested in previous study as a potential predictor of the preeclampsia. So despite the role of inhibin A, predicting the preeclampsia hasn't been investigated in Thai population. So this prompting us about this research. So the next about the objective. Our study aimed to assess whether the inhibin A level during the second trimester could predict the development of preeclampsia. We also aim to investigate other maternal risk factors like maternal age, BMI, and other conditions that can happen during pregnancy, all of which are known to increase the risk of preeclampsia. So the data was analyzed come from 1,766 pregnant women who underwent the credible test at Maharat Nakhon Ratchasima Hospital between November 2020 and November 2023. About the methods, we conduct a retrospective analysis. Reviewing the medical records of these women, we focus on inhibin A level, examined with two thresholds. The first one, more than or equal to 2.0 multiple submedians, and the second one, more than or equal 0.71 multiple submedians. We compare this level to occurrence the preeclampsia and evaluate to the significance of other factors that include like maternal age, BMI, and the pre-existing condition like hypertension and diabetes. And how about the results? The key findings: inhibin A more than or equal to 0.0 multiple submedians did not show a strong association of preeclampsia. This suggests that high inhibin A level at this cutoff may be not reliable for predicting preeclampsia. And the second one, however, inhibin A more than or equal 0.71 multiple submedians demonstrate the better sensitivity, meaning it's identify women at risk more effectively, but its lack of high specificity mean it was not effective to the exclude women who wouldn't develop preeclampsia. The third, beta HCG emerged as a statistically significant in predicting preeclampsia in this finding, suggests that beta HCG may be more reliable, to be biomarker for early detections. On the conclusion, in the conclusion, which inhibin A may offer some value in identify women at risk for the preeclampsia, but beta HCG may be reliable marker. Additionally, addressing maternal risk factor such as age, BMI, and coexisting conditions, maybe improving the early detection and reducing the impact of preeclampsia. This study highlighted the importance of referring screening the methods and taking a proactive approach to manage the risk factor of pregnancy. Thank you.
Please give a round of applause. And this is another fascinating presentation. Any concerns or questions you would like to raise?
Thank you for good presentation. So I would like to ask you, this is a diagnostic study, right?
This is descriptive.
So do you show the sensitivity, specificity, PPV or MPV for the inhibit A level or beta HCG level, or do you do the like the prediction to determine the like to diagnosis of the preeclampsia?
Yes, sorry. The first one I will explain the cutoff that we choose more than or equal 0.71. About the sensitivity is around 13.40 and the specificity is around 91.0 yes, and about the NPV it's around 41, and about the PPV it's around 70, and the last one around for the OR it's about 1.64. Yeah.
And for your result, do you recommend to measure the inhibit A level or beta HCG or nothing to do?
About my research, depending on the several studies aiming to aim the cut point around 2.0 multiple medians, but in our area, it's more likely to be like 0.21 multiple medians, may be significant. So we try to find the association of the other levels or other risks. So we think that the beta HCG associated with inhibin A level at this 0.71 level maybe help to find the association about inhibin A level, beta HCG, and preeclampsia.
So did you explore more in terms of any factor that could affect on the inhibin level? Like the times to draw the blood, the way that you store the blood sample, like that?
For that for this time, I'm not that I explore more about the inhibin A because in our area, Maharat Nakhon Ratchasima Hospital, it's only record the inhibin A level that come from the system. We didn't explore more about the inhibin A level that reliable at this time. So in the further research, maybe inhibin A may be more explored to develop the more association between the inhibin A and the preeclampsia. Thank you.